Hi everyone, this is Dr. Duello again recording a lecture for you. I am in Houston this next week for 3 days for the first international conference dealing with medicine after the Holocaust. I'm not going to tell you all about it now, but when we get to the portion of the course, the lecture on ethical issues in medicine and health disparities, I'll tell you about it then. There were a lot of atrocities in medical research that happened during World War II and under the Nazis. A lot of ethical implications that still ramify from that. So that's what this meeting is going to be about. What I want to do right now is remind you that we have a midterm exam coming up. It's on Tuesday, March 17th at 10 a.m. in this lecture hall. It will all be essay questions. Again, I'm not a great fan of multiple choice. I don't do well on them myself because I overthink them. So if you write, you get to tell me what you really know. So one of the things you should be thinking about are the questions that you have, and not to contact me the day before the exam and go, what about this, what about that? Email me any questions now or ask me in class and I'll send out the answers to everybody. Okay, thank you much. Want to review a couple things. In the last lecture that I videotaped here, we talked and you understood this about phase 1 of the Human Genome Project, showing that we're 99.9% identical at the DA level. There is no genetic basis for race. I talked about what accounts for the other 0.1%, and I just want to reiterate, we talked about genetic drift, small genetic changes over geographical space and time, natural selection, i.e. survival of the fittest, the founder effect, which is when certain characteristics reside or even are amplified in a group because they're basically reproducing within the group due to geographical isolation or by choice. And then mutations, and mutations can happen anytime. The molecular biologists will tell you there probably are no perfect human beings, and we all probably have somewhere between 3, 10, 12 mutations at least. I'm sure I have a few. The point I want to reiterate here is that genetic drift, natural selection, and the founder effect, okay, are all happening over longer periods of time. Genetic drift, definitely over evolutionary time, okay? Natural selection, not over a generation, over two, again, over a long period of time. The same thing with the founder effect, many generations, not one. However, mutations can happen at any time. So understand that you do not have genetic drift within 1 or 2 generations. So here now I would like to go and talk a little bit about the biological determinants dictated by the DNA sequence. So let's take the situation that there is a certain genetic makeup at conception. The egg and the sperm get together and there you are. You may have received some mutations from mom or from dad. There's also your genetic makeup at birth, and in the best of all worlds, your genetic makeup at conception and birth are the same because nothing deleterious happened while you were in utero, And then there are the genetic changes due to mutations in the DNA itself, changes in the sequence. I want to clarify, students are sometimes confused that there are also biological factors that affect your health that are not based in the DNA sequence. And this is the whole field of epigenetics. Epi means nearby the DNA sequence. So epigenetic changes are changes in gene expression or the cellular phenotype that are caused by mechanisms other than changes in the DNA sequence, the base alphabet. So that may be DNA methylation, histone deacetylation, where, for instance, an increase or decrease in methylation may turn on or turn off, deactivate a gene. So this is not a mutation within the DNA sequence, but modifications of the DNA that affect gene expression, okay? The next one that actually is huge is the physical environment. And just given the size of this issue, it sometimes confuses students. So the physical environment is everything around you, everything that impacts your physical well-being. So everything that touches you, the food quality, food contamination, water quality, water contamination, soil quality, pesticides, toxins, everything in the physical environment that may have an impact on your health, a deleterious, negative impact on your health. So your physical environment is everything you absorb, ingest, and inhale, and in terms of health disparities, that could be bad for you. A lot of good things too, but we're talking about the bad ones. Okay, so again, I want to clarify that there are genetic biological factors and there are non-genetic biological factors. And again, just think very broadly about your physical environment. If you drink bleach, you're going to die, not because it changed your genetic code or your inheritable characteristics, because it's toxic, because it is lethal. So all of the toxins, pesticides, anything that can be deleterious are in your physical environment. So now I want to switch, change lanes just a little bit here. And because obesity is such a huge problem in the United States, let's talk about that. And let's talk about the food we eat, our diet as part of the environment. So some of you, I can't see you raise your hands here, but some of you have probably seen the book Fast Food Nation, which was a pretty scary book, and more of you might have seen the movie Super Size Me. If you haven't, go on Netflix and or Amazon, whatever, and check it out. Basically what this individual did was decided that he was gonna eat all of his food for how many weeks? Month, 2 months, and that from McDonald's. And this was when you walked into McDonald's and you made an order and they said, can we supersize you? Which means you got the jumbo fries and the jumbo soft drink and everything else. This man was under the observation of a physician, and the whole movie just documents how his health went downhill from totally eating fast food. So that's definitely one that you want to see at some time. I'm going to show you a series of slides about obesity in the United States so you can get a feel for how big the weight issue is in the United States. Basically, you can take just about any disease and it may be aggravated by being obese, cardiovascular disease, any kind of hypertension, diabetes, on and on and on. The major diseases, chronic diseases that plague Americans. So I want to just clarify here that in these slides, we're going to talk about BMI, body mass index. And basically what it is it's a formula that takes your height and your weight and says for a person of your size, are you underweight, of normal weight, overweight, or obese? And you can go anywhere on the internet and figure out your BMI here. So one of the things that has happened here in the next slide, you can see we're going to talk about obesity trends in the United States. And what you can see here, this is the Center for Disease Control, and it's behavioral risk factor surveillance system, surveys basically. And what they have done is defined obesity as having a body mass index of over 30, which is over 30 pounds overweight for a person who's 5'4". So that's a fairly short individual, but again, BMI calculates your height and your weight to do body mass index. So in this first slide that you can see, we've got the United States. The box indicates that if we have no data, the state is white. But if fewer than 10% of the people in this state are obese, it's light blue. And if 10 to 14%, it is the darker blue. So you can see Wisconsin back in 1985, okay, we had between 10 and 15% of our population who was considered obese with all of the health problems that are associated with that. So what I'd like you to do as we go through these slides is keep one eye on Wisconsin and one eye on some other state and watch the changes in this map as we go forward. And hope to not make you motion sick here doing this. So this is 1985. We look at Wisconsin, okay? In 1980, okay, here we have 1986. So you can see not a dramatic change yet. But again, watch Wisconsin and another state. We're going to go from 1986 to 1987. We've picked up Maine, Texas, South Dakota, a few more states. 1988, more states with over 10 to 14% of the population being obese. 1989, 1990, 1991. Now here, obesity has gotten so severe that we've had to create another category. So the very dark blue are states where 15 to 19% of the population is obese. So here we have 91, 92, picked up Kentucky, 93, 94, 95, 96, 97. Okay, we have so much obesity in the United States that we had to create another color, this light yellow, for over 20% of the population being obese. 98, 99, 2000, 2001, another color. Orange state here, Mississippi is over 25% obesity. 2002, 2004, 2005, look at here, over 30% in West Virginia, Louisiana, and Mississippi. 2006, 2007, 2008. So that, folks, should be upsetting. These are the kind of changes that we're seeing as we become more and more overweight and more obese. And as I say, obesity affects so many other diseases, especially diabetes and cardiovascular disease, etc. Okay, one of the things that's really upsetting as well is that in the last decade or so, we have seen more and more type 2 diabetes at a younger and younger age. So it used to be that type 2 diabetes, type 1 diabetes is the form juvenile onset diabetes, which you may be born with, or it's at a very young age. Type 2 diabetes, it used to be that if people had type 2 diabetes, it would occur in their 50s or their 60s. It has moved back to 40s, 30s, 20s. So now you can see in the next one that we have such a prevalence of obesity among children and adolescents. This is ages 2 to 19, and this is done by a National Health and Nutritional Examination Survey, which is also the CDC. And you can see from 1971 up to 2003 how much more type 2 diabetes, obesity we have, and this is associated, with type 2 diabetes, which is shown in the next slide. So here you can see the association. This happens to be a 1994 slide with obesity on the left, and look at the incidence of diabetes on the right. This is 1994, 1999, and 2008. So there is no question that we have a humongous problem in the United States. There is no question that this is a certainly affecting the health of many people, and certainly health disparities to the poor. This goes back to socioeconomic status. What foods can you afford? What is available? What is clean? What is cheap? On and on and on. So huge issue here. So this goes back to, folks, one reason why I had you keep a food diary. And the pedometer too, because again, diet and exercise are huge. And I can tell you, over the 7 years that I've been teaching this course, the class's health, I think, has improved. A lot of you eat very, very well, which is great to see, and you get the exercise. And I can tell you, when I taught this course 5-6 years ago, one of the students wrote a reflection, and it said, boy, this exercise has been really, really wonderful. I used to drink one 32-ounce bottle of Coke every day, or excuse me, 2 32-ounce bottles of Coke every day, and now I've cut down to 1. So I guess it's how you define progress, but definitely eating well, and you all wrote about the challenges of that too. This is an older slide, but the point is still valid. I showed this before to show the burden of diabetes, heart disease, COPD as chronic obstructive pulmonary disease, respiratory diseases, emphysema, hypertension, high blood pressure, and asthma. And at the very beginning of this course and in the course announcement, I talk about the burden to disadvantaged Americans, racial and ethnic minorities. One of the things that we saw in our discussions of race is this is not about skin color, it's about socioeconomic status. And of course, one of the factors affecting socioeconomic status is our history and how we have treated the enslaved Africans that came here, and immigrants as well. Remember, we're all immigrants except the Native Americans. So I'm going to take another big shift now, because one of the things that I showed you was Directive number 15 from the Office of Management and Budget that said, again, that race is neither a scientific or an anthropological term. It is a social category. The data collection came out of the desire to do record keeping, collection, presentation of data on race and ethnicity to make sure that we were not discriminating in housing, in education, in banking, on and on and on. Now, one of my big objectives in this course is, of course, to tell you about health disparities, but another one, certainly probably number one, is to get you to think critically. Okay, decide what you want to believe. Decide whether it's based on data. Okay, look at the facts. So I want to tell you a story that I think will shock you. It did. Whoops, wrong slide. Here. Back in 1980s, probably, somebody registered a drug called BiDilshown. And actually, it was 2 very, very common drugs that had been used to regulate blood pressure for 20 years. So one of the ways you lower blood pressure is that you vasodilate, you expand the blood vessels, you have a bigger bore, the blood can go through with less resistance, there's less pressure on the blood vessel wall, and blood pressure goes down. So if you increase blood pressure, you constrict the blood vessels and put the same amount of blood through a smaller space. Vasodilation is opening the blood vessels. That's what happens when you flush. Your blood vessels are vasodilating. So we don't have to go into all the chemistry here, but there were 2 very, very common generic drugs that had been in use for 20 years. One was called isosorbide dinitrate, the other was called hydralazine. And what had happened was these drugs had been prescribed for a long time, but this company decided to put them in the same pill. What they did was, back in 1980-85, they did a big quote-unquote clinical trial, a big research study looking at heart failure. And again, we don't have to go into all of the details here, because what we want is the big concept. So there was this heart failure trial from 80 to 85, and they set up this clinical study, and in 1987 the company put in an application for a method patent on the combined use of these two generic drugs. Now when you go after a patent, you can go after a patent which describes something entirely new, or you can go after a method patent which is a new application of something that existed. So in 1989 the patent was granted for this this combining these two generic drugs. Then they decided to do a second clinical trial that went from 86 to 91, and it was another large one looking at heart failure. And what they did was compared BiDil, this combined drug of these two generic drugs, to something else that regulated blood pressure, and that's what the enalapril is here. So ACE stands for angiotensin converting enzyme. Don't worry about that. But what they were doing was comparing two drugs to lower blood pressure. And what they concluded was that when you use the combined drug, the BiDil, that there was, that it worked. Okay? So what happened now, we're going forward, and the company was doing more clinical testing, and what they wanted to do was compare the drugs given in one pill combined versus given two pills administered separately. And what they showed, this is a standard research procedure. 2 years later they came out and said BiDil, which is what this drug was called at that point, was bioequivalent, meaning whether you combined them or whether you took them separately, you got the same outcome. So they went to the Food and Drug Administration and they applied for a new drug. Okay, so these were two generic drugs that had been around for 20 years, and they applied for a new drug application. And in 1997, it was turned down. When you put in a patent application, you have to go through the whole justification of what you did and why, and a controlled study. What were the variables? What were your endpoints? How you were controlling for these variables? Well, they said, you know what, you've got too many variables here. That you started out and you did one clinical trial from 80 to 85, and then the study was kind of modified in the second clinical trial, so your endpoints have changed, and this is difficult to interpret, so they turned it down. So now 3 years later, same outfit came back and put in a patent application and said, oh, surprise, this drug works better in African Americans, a social category. So they said the drug works better in African Americans, so what we want to patent is use of this drug only by African Americans. Well, I don't have to talk much more to explain to you the problems with that. Number one, my physiology isn't any different from another African Americans, and I happen to have high blood pressure. So if this drug works for African Americans, it's going to work for me, right? So why can't I have it? Why are they using a social category, especially going back to Directive Number 15 on the Office of Management and Budget that said African American, race and ethnicity are not scientific terms. So what happened in 2002, a patent was actually issued by our own United States Food and Drug Administration, and they said that the patent was issued on, quote, methods for treating and preventing mortality, death, associated with heart failure in African American patients. Now I'll tell you what, go back to probably the first lecture I gave you where I talked about incidence, okay? And one of the things I said was that you can have the same burden of disease to two populations, but you may have more fatality, mortality, death in one group, but it's for a multitude of reasons, okay? It may be that the individual did not have a doctor. They were not insured. They maybe had minimal health coverage, and they didn't have transportation to the doctor. They couldn't afford the prescription they were given. They couldn't afford good food and exercise, sports, school sports even, to get exercise, whatever. Maybe they didn't have health education. Maybe they didn't have opportunities for screening. Maybe they went to the doctor and the doctor was not sufficiently inquisitive. Maybe the patient wasn't forthcoming. Maybe the patient was diagnosed and way down the pike there was some procedure that the patient couldn't afford or that they weren't told about. So you have two populations of people who have the same burden of disease, but one has more death. And that's definitely the case of heart failure among African Americans. The FDA approved a drug based on a social category created to justify slavery. 3 years later, the patent was issued. The FDA approved it, BiDil, for self-identified African Americans. Okay, go back to Raise the Power of Illusion and go back to that category on sorting people. Do you know who's African American and who's not? Okay, I may have African, well, I do, you go back far enough, we all have African ancestors, but you may look at an individual and not, so it's self-identification. So what happens is this was such a mess that someone with much darker skin than I could go in and say I'm African American and get this drug, and I could go in and say I'm Caucasian and I couldn't get this drug, or I could go in and say, hey, guess what, I'm African American and I can get the drug. What is scientific about self-identification? Ridiculous. So of course, the media got a hold of it, and the New York Times and a lot of other places, they love to give us names and titles and everything else, and they called this the first ethnic drug. Okay, folks, let's go way back to the beginning to what is ethnicity? Okay, ethnicity is your belonging to a group of people, a common group with whom you identify. They may be the same race, they may be the same nationality, they may be the same religion, they may come from the same geographical area or have language in common. They may have shared ancestry, shared memories of the past, the same emblems of their cultural history. They may feel like a group. They have their peoplehood. When I told you about talking about ethnicity and thinking of it as what is in your suitcase that defines you. So I'm Caucasian, I'm a U.S. citizen, I'm from Wisconsin, I'm from Dane County, I was raised Catholic, historically I'm German and French, I only speak English on a good day. That's my ethnic description. How are we going to do pharmacology on the basis of ethnicity? Okay, so I'm on a roll, right? So I studied this. I even went and looked at the patents. I said, how can this be? So this, just in summary, is the rationale that they gave to justify for this patent. So the first one that they said, there is a disparate burden of heart failure among African Americans. Disparate, unequal and unfair, and definitely that is true. That happens to be a fact. It's not a scientific finding. The study came back and said that there's a ratio of 2 to 1 mortality rate due to heart failure. Twice as many black people die in mortality than white people do. We'll look at that in a second. They also said that this one category of drug, these ACE inhibitors, weren't effective in African Americans, so we needed something else for African Americans. They also did very limited studies that said there was an ethnic difference in the way cells use nitric oxide in African Americans and Caucasian Americans. So the whole nitric oxide production and utilization is about regulating the vasodilation and expansion of blood vessels. So they said there was something different in the physiology or something between African Americans and Caucasian Americans. The only thing they got right was that there is more mortality, and they claimed there was a 35% decrease in the mortality rate due to this drug. Now I'll tell you, when you get in big quagmires like this, one of the things I like to do is to start out and say, okay, what is this not about? So we can take that off the table and then decide what is it about. So what is the controversy? What is not controversial about this? So there is no question that African Americans suffer a great burden of high blood pressure and heart failure. Unfortunately, that's true. There's no question that this is a very important health disparity, and we have all of the studies that have been going on forever on this issue. There's no question that it's equally important to identify hypertension and heart failure in the rest of the population. My father's side of the family is solid with hypertension. I have 7 brothers and sisters. We're all on antihypertensive medicine. So what is the controversy about if it's not the particular points? So it was the use of race as a biological category, and whenever they've used the term race wrong, I put it in parentheses here, and errors in the science, in the experimental evidence. What's the difference between science and news in the New York Times that calls something an ethnic drug? Now, we could go through a whole research course on this, but just let me give you enough information to tell you why this was really wrong. So what you have is, it started out, we said part of the rationale was that there's a disparity, a health disparity, a disparate burden of high blood pressure and heart failure among African Americans, and that's true. And then they came back and said twice as many African Americans die of heart failure as Caucasian Americans. And what they did here is they made a statistical error, okay? So what it comes down to was they compared dissimilar groups. So they had an age group of 35 to 74. Well, 50% of the heart failure occurs in this age category among African Americans, but only 30% in whites. So if you move the age up further to 80 something or something, what you find out is that there's not a 2-to-1 difference, it's 1.1 to 1, okay? So the data didn't account for the fact that 71% of Caucasian Americans mortality due to this occurs after age 74. So it was not a good use of statistics, okay? Inaccurate. Next thing they said was that this particular vasodilator to reduce high blood pressure in African Americans didn't work. Well, I'll tell you what, if you're going to read the literature, scientific literature, you have to be analytical, use critical thinking, and I could pull up 3 papers that said this was true. I could pull up 3 more that said it wasn't. And anytime you're looking at a study like this, how many people did they study? Were they similar groups? Did they have the same health history or not? This is why geography is so incredibly important. You know, what the causes are for obesity in one state versus another can differ. Dane County versus Brown County versus Menominee County, all of these may differ in that. So you really have to compare populations, similar populations, sampling size, on and on and on. This is disputed. There's no solid data that there's any difference in how African Americans process this drug than anybody else. The next one, they said that there was a quote-unquote ethnic, and again I put things in quotations when they're used wrong, an ethnic difference in the way cells use nitric oxide among African American and Caucasian Americans. So I can tell you as a biologist that this put me through the roof, okay? So 2 of the studies only looked at vascular resistance. That means they took your blood pressure. So in one group they had 39 African Americans and 39 Caucasian Americans. And out of 78 people here, they concluded that there was a difference in blood pressure, folks, not pathophysiology, between these two groups. How many millions of people are there in the United States? Why would 39 people sample anything, and how were they chosen? The next one was also a blood pressure study. 13 African Americans, 14 Caucasian Americans, and they said there was a difference in blood pressure. No kidding. That's not profound here. There was one study where they actually did a kinetic study. They took cells in culture and they actually looked at nitric oxide production and its use. Now the catch here is they used cells from the umbilical cord that connected you to mom. And they took the cells from the umbilical cord and they put them in culture, and they had 13 African American women, self-identified, and 12 Caucasian women, and they took these cells and they concluded on the basis of these 25 people that there was a difference in these populations. Well, number one, that has no meaning. The sampling, how they chose the people, the similarities, on and on and on. The other thing, as I've told you, I think I have my PhD in human anatomy, embryology, cell biology included there. They wrote this entire scientific paper, and not once did they understand that the cells that they were looking at were from the baby, not from mom. Okay? So the genetic makeup of the umbilical cells are mom and dad, not just mom. They didn't even get it. They didn't even understand the origin of the cells. So they did say there was a 35% decrease in black mortality. Now this is still pretty confusing, but again, let's go back to all of the reasons why there might be a difference in mortality rates and why there might be a 35% decrease. So I don't know this for a fact because this is not understood, but possibly, maybe, kind of, sort of, perhaps, what if you had somebody who was uninsured and their high blood pressure went undiagnosed, and by being in a clinical study, their high blood pressure was recognized, and then they were given a drug that would lower that blood pressure. They had follow-up, they had health education, they had screening, they had care, they had access to the drugs, and their blood pressure went down. So I went over and I asked the people in the heart transplant center at UW Hospital, one of the top doctors, what do you make of this? And what they said, and I have no reason to not believe this, is one of the reasons you have mortality is that if you have high blood pressure for a long, long time, what happens is you're just wearing on the wall of that blood vessel. And what happens is you max out and you have heart failure because you've worn out that blood vessel. By lowering the blood pressure, you're reducing the wear and tear on those blood vessels, with the result that there is less mortality, less death. So it's not clear from any of the papers written. Theoretically, they should have done a study, a double-blind study where they knew this, but we don't really know why. But I will guess, and it is a guess, that it's because people got health care and because they got their hypertension under control before they burned out. Okay? This, folks, is about critical thinking. Our own government, U.S. Food and Drug Administration, approved this, and the U.S. Patent Office gave it a patent. And then they said that this is, normally you get a patent for 7 years. And it's, you did all the hard work and the discovery. For 7 years, this product belongs to you. After that, it's wide open to everybody, and this is when every pharmaceutical company comes out and makes a generic drug, because you no longer have exclusive rights to this. The U.S. Patent Office said, golly gee, wow, this is so unique that we're going to extend the patent to 20 years instead of 7. This is all a farce. So let's go on. There is a wonderful book by Joseph Graves Jr. He is a geneticist, and he also writes great things on misconceptions of race. And he has, I can send them to you, but there's one book that he has called The Race Myth. how we confuse our thinking about race, and the other one is the Emperor's New Clothes. And what he put here is that I'm going to show you 6 common errors, common mistakes in associating race in parentheses with complex behavior. Now, Dr. Graves wrote this all way back in that when there was a big thing about the bell curve, and they tried to say that different racial groups differed in their mental abilities, blah, blah, blah. Big trouble, okay? So the common errors are making claims that are not substantiated by the data. And go back and look at the rationale, look at the data I showed you, and especially like, that the certain drugs, Nalopril and that don't work in African Americans, just bad science. I always say there's no such thing as bad science because bad science isn't science. So one problem is making claims that the data doesn't support. One is making mathematical or statistical errors which support one's hypothesis, and this is what they did when they said there was a 2-to-1 difference in mortality rates. They were not looking at the real data. Even if they had the same age group, they weren't taking it correctly into account. Ignoring alternative hypotheses that can also explain the results equally well. And as a scientist, you always have to be on guard about this, that this isn't your pet hypothesis for how you think it works. You always have to be open to everything. Same thing with ignoring data inconsistent with one's own hypothesis. It's like you have a plot of data and, a couple of points on the graph don't fit, and you go, oh, well, those were probably a mistake. Well, this is why we do all scientific experiments in triplicate. If it's not reproducible, it's not science, okay? Keep going here, ignoring theory and data that challenge your core assumptions. If you start out with the core belief that race is a biological entity and you don't give that up, then you're not entertaining the other possibilities. Now, big challenge, making sweeping policy recommendations that conform to racist philosophies and practices. What would we do with a drug that could help everybody or no one, which was only available to some people? If it really worked, then I couldn't get it, and everybody else who could help couldn't get it if it wasn't for my group. Or else it's deleterious and we wreak pain and havoc and misery on some population. And we talk about ethical considerations in a couple of lectures. We're going to talk about this too. So, big one here. If you don't get anything else out of this course, think about this real hard. So we have all of these rules and laws and regulations to protect human beings. I don't like the term human subjects. Human beings when they are studied. And the first half of all of the human being ethical protection was do no harm, do no harm, do no harm. And this was the aftermath of World War II, the Nazis, Hitler, horrible things, experimentation on people. And then in 1979, there was this big National Commission for the Protection of Human Beings in Biomedical and Behavioral Research, and it got nicknamed the Belmont Report. And what came out of the Belmont Report, the big message, was it is not sufficient to just say, do no harm. We also have to have respect for individuals. All populations should equally experience both the benefits and the risks and social justice issues. And we're going to talk about some big violations a couple of lectures down here, but to also talk about all the things that are in place to make sure that history doesn't repeat itself. So, what it is my concern about policy, my concern about healthcare in the United States is that as we continue to use the term race incorrectly, you will see things that say that you need to recruit underrepresented people, minorities to clinical trials. This is not because there is a black physiology that's different from a Native American physiology, that's different from an Asian or a Hispanic Latino physical therapy or physical situation, okay? So we all have the same physiology. What it is that these people are Americans. We do not have everyone represented in our scientific studies. The justification is not that they differ physiologically or genetically, but they should be represented because we should be addressing everybody's health and studying all health issues. Obviously, I could go on for a very long time about this, but I'm going to stop right here. Again, if you have any questions at all on the first lecture on biological determinants, on this one at all, please send them to me. We'll recap a couple important slides as we review for the midterm too. But again, think so much about this. Misconceptions of race in medicine. Okay? We do not study the poor, the underrepresented, and racial and ethnic minorities, people in different socioeconomic status because they are genetically or physiologically different, but because of all of the factors about both our social and our physical environment. Take care. See you when I